All right, it's 8 o'clock. I'm Patrick Fau from the section of Gastroenterology, and I get the honor of introducing our speaker for today, Dr. Jennifer Weiss, also from the section of Gastroenterology in the Department of Medicine. Dr. Weiss is a native of upstate New York, and she went to undergrad at Cornell Medical School at the University of Rochester, further education here at UW with a master's in publishing science. She did her residency, then chief residency and GI fellowship at UW. Also did a postdoctoral fellowship here at UW in health services research and healthcare quality improvement. She's been on faculty since 2009, officially gained tenure in 2019 when she became an associate professor. If this talk was a month later, she'd be full professor. She's almost a full professor. She'll be in a month or two. Dr. Weiss is actually really the true triple header of medicine with clinical mentoring and research. Clinically, she has set up and established and leads our University of Wisconsin GI Genetics Clinic for mentoring. She actually is the associate program director for our medical residents here for medical resident research. She's mentored well over 20 postdoc fellows and graduate students in research projects that have gone on to full publication. Her talk today will be about her research focus, and her research focus is on colorectal cancer and really colorectal cancer screening, on increasing colorectal screening, improving systems that lead to improvement in colon cancer screening. And really in the last number of years, her focus of research is what the topic of today's talk is decreasing colorectal cancer screening disparities across vulnerable populations. This has led to multiple publications, over 60 publications on colorectal cancer screening, including multiple national guidelines on colon cancer screening. She's funded by multiple resources. I won't, and grants. I won't list them all, but I will list a few that correlate to this talk. Her research really correlates with this constant idea. She has grants to study the successful screening strategies across urban and rural Wisconsin. She has a grant to identify screening strategies in rural communities in Wisconsin. She has another grant of developing structural Wisconsin partnerships to address healthcare disparities. All this research has led to multiple talks throughout the state, throughout the country, and even internationally. She sits on all the she's on multiple committees that write the guidelines for colon cancer screening. She is actually a true expert on colorectal cancer screening. She's a significant resource for all of UW Health, and we feel very fortunate to have her in our section and in our department. And so she's going to talk about her research today, and then the title of her talk is Beyond the Rural-Urban Divide, a closer look at disparities in colorectal cancer screening. All right, Jen, it's all yours.
Thank you. Thank you so much for the introduction. So as you heard, I will be talking about Beyond the Rural-Urban Divide, and make sure you guys text this code to the number to get credit for signing in and attending grand rounds. I have the following conflict of interest disclosures. So I do have, I am a site PI for some multi-site studies with Exact Sciences, and I do not intend to discuss any unlabeled or unapproved uses of drugs or device during this presentation. So just a spoiler alert to everybody, there are disparities in colorectal cancer screening. I know this is a huge shock to everybody, but what I'm hoping today is that we can delve a little bit deeper into what those disparities are. So by the end of this talk, you should be able to define national trends and disparities in colorectal cancer incidence and mortality, define trends in colon cancer screening disparities at the national level, and then be able to compare and contrast nuances of geographic disparities in colon cancer screening in Wisconsin. We're going to start by talking about disparities in CRC incidence and mortality, then go into trends in racial and ethnic disparities in colon cancer screening nationally, brief talk about National Geographic disparities in colon cancer screening, and then really delve a little more into what is happening in our own backyard within Wisconsin. And that'll be where I talk a little more about my research into racial and ethnic disparities in colon cancer screening in Wisconsin and rural and urban disparities in Wisconsin. So as we know, colorectal cancer matters. It's the third leading cause of cancer-related deaths for men and women in the US. And in 2024, there's an estimated 152,810 new cases and 53,010 estimated deaths from colorectal cancer. So even though we are making dents in incidence and mortality overall over the past 2 decades, there still is it still is a very common cause of cancer mortality. Rebecca Siegel's group, which actually produces the cancer mortality statistics and just the cancer statistics overall, in 2023 published a paper specifically on colorectal cancer statistics. And they showed that the burden of colorectal cancer varies greatly within these broadly defined racial and ethnic groups that are shown on this slide. And what I really wanted to point out is that the rates of colon cancer incidence and mortality are highest among American Indians, Alaska Natives, followed closely by non-Hispanic Blacks. And they're lowest in the Asian Americans and Pacific Islanders. And 3 years prior, when they published a similar paper in 2020, the non-Hispanic Blacks and American Indians and Alaska Natives were just flipped. So it really just keeps flipping back and forth between these groups, but we're starting to see a significant breakaway with American Indians and Alaska Natives having more significant disparities. Cancer occurrence and outcomes vary considerably between racial and ethnic groups, and we think this is largely because of inequalities in wealth that lead to differences in risk factor exposures, barriers to high quality cancer prevention, barriers to early detection, barriers to treatment. And Rebecca Siegel's group showed that the magnitude of the disparity for mortality is actually double that for incidence. And even after controlling for risk factor prevalence, non-Hispanic Blacks are less likely to receive both timely follow-up of a screening test and high-quality colonoscopy. So that goes into these inequalities in access to high-quality cancer prevention and barriers to early detection. Iris Lansdorp-Vogelaar published a paper a number of years ago, but it actually still really holds true today. Her group used the MyScan colon microsimulation model, and they used it to estimate colorectal cancer incidence and mortality in Blacks aged 50 and older from 1975 to 2007, and assumed that they had the same trends in screening as rates as whites instead of what was being observed. And they also assumed that they had the same trends in stage-specific colorectal cancer survival rates as whites instead of what was observed. And looking at these assumptions and looking at the trends, they concluded that enabling Blacks to achieve equal access to care as whites would substantially reduce the racial disparities in colorectal cancer burden, again, supporting the fact that a number of these inequalities are due to barriers in access to high quality care and early detection. We also know that there are differences in colorectal cancer incidence and mortality across geography areas. So there's differences in the US in prevalence of colorectal cancer risk factors, such as smoking, BMI, access to high quality healthcare, and then this results in large geographic disparities. Rebecca Siegel's group in that same paper in 2023 showed that the lowest colorectal cancer incidence and mortality rates are in the West, and the highest are in Appalachia and parts of the South and the Midwest. And more specifically, incidence rates range from 27 per 100,000 population in Utah to 46.5 per 100,000 population in Mississippi. And mortality rates range from 10.6 per 100,000 in Utah to 17.6 per 100,000 in Mississippi. We also know that there's differences with respect to rural and urban areas. So rural counties have a disproportionately higher incidence and mortality from colorectal cancer compared to metropolitan counties. And between 2009 to 2013, the incidence of colorectal cancer in rural counties was 13.4% higher, and mortality was 15.6% higher than metropolitan counties. And just kind of a back of the envelope calculation, this translates to 14,200 excess cases and 6,050 excess deaths in rural compared to urban areas from colorectal cancer. So we've talked about trends in disparities with respect to colorectal cancer incidence and mortality, but this data has also shown us that maybe we can help significantly reduce these disparities by increasing access to high quality care, such as colorectal cancer screening for early detection and prevention. So we need to delve into the disparities with respect to colorectal cancer screening. So we're going to start with racial and ethnic disparities at the national level. So Fola May from UCLA took data from the Behavioral Risk Factor Surveillance System survey and looked at repeated cross-sectional analysis of average risk adults over a number of different time years. So they looked at each survey year between 2008 and 2016 to determine significant trends in screening rates over time by race, ethnicity, as well as screening modality overall and by race, ethnicity. And what I want to point out here is if you look at the different time points in which they looked at the survey data, there's two important time points to think about. So one, the Affordable Care Act was implemented in 2010. So looking at that as kind of an anchor. And then the second time point is that Medicaid expansion states experienced increased access to screening in 2014. So just thinking about that as you're looking at the data. And we see that overall, the screening rates improved from 61% to 67% over those years, which is great. We also see that rates for whites were highest in every survey year, also not surprising. With the BRFIS data, we see that Blacks had the second highest rates in most years. And now this, to think about the BRFIS data, if you're not familiar with it, this is self-reported colorectal cancer screening by the respondents. And Hispanics had the lowest rates in most years. So using this national data set, Fola's group showed that there were disparities and trends based on racial and ethnic groups in colorectal cancer screening over time. They also looked at the trends and how things change. And they found that for whites, Hispanics, Asians, and multiracial individuals, there was a significant increase in screening rates over time without any discontinuity. So just continued increase in screening rates. But for Blacks, the screening rates increased from 2008 to 2014 and then hit a plateau. And for American Indians and Alaska Natives, there's only been a very small increase since 2012. But what I thought was really important from this study is that for Blacks and American Indians and Alaska Natives, the disparity in screening compared to whites actually increased from 2008 to 2016. So even though overall rates might have been getting a little bit better, the difference between these groups increased. These results were also consistent with other large cross-sectional analyses utilizing the National Health Interview Survey and Healthcare Effectiveness Data and Information Set. So in response to that paper that was published by Fola May's group, Josh Dem and Samir Gupta from UCSD decided to look at that impact of the Affordable Care Act and look at what it would take to really achieve the National Colorectal Cancer Roundtable goal of 80% screened in every community. And what you can see from this graph, that in order to achieve that goal, an intervention would need to be capable of increasing screening by 9.6% for whites, but also a range of 11% to 26.6% for racial and ethnic minorities. So in order to reach that goal of 80% in every group, we would have to make differences that are varied across the different racial and ethnic groups. And so their conclusion is that achieving health equity will require going beyond just this one size fits all approach of implementing a national policy. And so the national policy helped, but our work is not done. We also know that there are geographic disparities in colorectal cancer screening nationally. And if you just look at the CDC data across the United States, and you can do this for lots of different measures, we have variation across the states. So this BRFIS data from 2022 includes adults ages 45 to 75 who reported receiving one of the following. So a blood stool test within the past year, sigmoidoscopy within the past 5 years, colonoscopy within the past 10 years, the stool DNA test within the past 3 years, or a CT colonography within the past 5 years. And again, this is patient self-report. Based on this data, we're actually doing pretty well. So Wisconsin is ranked number 5 with an overall screening rate of 65%, and California is ranked 50 with an overall screening rate of 52.4%. So you can see there is variation at the state level. I wanted to look a little closer to home first. And so Karani et al. Did a study where they looked at association of neighborhood measures of social determinants of health and rurality with respect to breast cancer, cervical cancer, colorectal cancer screening in the US Midwest, so in multiple states. So with respect to the colorectal cancer screening data, they did a cross-sectional study of adults receiving care at 75 primary care practices in Minnesota, Iowa, and Wisconsin. And they were able to identify a little over 145,000 adults who were eligible for colon cancer screening. And they looked at the association between ADI and receipt of screening, as well as rurality and receipt of screening. And in this study, rurality was defined at the zip code level, and they classified it into 3 groups: urban, rural, and highly rural. The first thing you can see is that overall, with respect to colon cancer screening, they found that individuals living in areas of greater deprivation, so using the ADI area deprivation index, had lower rates of colorectal cancer screening completion. They also found that individuals living in rural areas had lower rates of colorectal cancer screening completion. But what I want to focus on in this table is that it was surprising to me that the difference between the likelihood of completing colorectal cancer screening between rural and urban areas was really not as large as I had expected, especially based on even just some anecdotal data that I know about here in Wisconsin. And so this kind of brought me to my current research focus, which is really trying to delve a little deeper into the differences across rural and urban areas. So what is happening in our own backyard? So we have partnered heavily with the Wisconsin Collaborative Healthcare for Quality to work on this issue. And one of the things that we have done is work with them on Wisconsin Health Disparities reports. And this is a report that is partnered with the Health Innovation Program where I do my research, and it was funded by the Wisconsin Partnership Program. And these health disparities reports are available on the WCHQ website. So on the next slide, I'll show their their website address, and anybody can go to that website. It's a publicly available website with lots of really great data about things that are happening in Wisconsin with respect to multiple metrics for healthcare. So who is WCHQ? They are a statewide voluntary consortium of 27 Wisconsin healthcare provider organizations, including health systems and medical groups, hospitals, clinics, and dental practices. And the mission is to bring meaning to performance measurement data by creating information that drives improvement in healthcare quality and affordability. And their overall vision is to improve health and increase the value of healthcare for all. And again, at the bottom right of the slide is the address for their website. It's really fun to actually just go on and play around and look at the data, and you can look at the measures that they report, which are anywhere from cancer screening metrics to immunizations, other preventive care measures, chronic disease management, and you can see how the different healthcare systems that are member organizations are doing across Wisconsin. And UW Health is one of the earliest joiners of this group. So we have a lot of data that's available on that website. The purpose of these Wisconsin Health Disparities reports was to provide a baseline information on disparities in health outcomes and care in Wisconsin to inform and accelerate programs working to eliminate disparities. And so we want to identify opportunities for improvement, build interdisciplinary partnerships among stakeholders, and then be able to track changes over time. The initial disparities report looked at these three groups. So we looked at race, ethnicity with the categories described by the CDC. We looked at payer disparities amongst payers, and we looked at geography using this binary categorization of rural and urban. The data sources for these disparities reports include electronic health record data from 25 of the healthcare systems that are members of WCHQ and report twice yearly to WCHQ. And this is longitudinal clinical data that's available at the patient level. So it's quite a extensive access to information. There were some small sample sizes, and so the healthcare systems and clinics that are included in this data had to have a minimum denominator of 100 individuals for the metric that was being measured. One major limitation, however, to keep in mind is that this data does not currently include federally qualified health centers, where we know Dr. Noel Acante has been doing some amazing work to increase screening rates at FQHCs across Wisconsin. It also does not include Indian Health Services clinics. And then there's some clinics in Northwestern Wisconsin that are not included in this data. At the population level, the individuals who are eligible to be included in the WCHQ data and be measured with the healthcare metrics have to have recently seen a primary care provider. It's slightly different for each metric, but that is another limitation to think about, because by limiting to those who have a primary care provider visit recently, we are missing a lot of individuals who do not have regular access to primary care, do not regularly use primary care. And so the report for these disparities may actually underestimate what's present. When we define disparities in these reports, we're looking at differences in health outcomes and care measures that are adversely affecting population groups seen in primary care settings. And we looked at kind of three different categories. So if there was a difference of 0 to 4% in the metrics between the highest performing group and the lowest performing group, we felt there was really no significant difference. However, if it was more than 10% difference in these metrics, then we consider that to be a substantial gap or a disparity. So just kind of a visual display of what you would see in these reports. You have potentially say these are the 4 different payers. You have the highest performing group, and then you have the lowest performing group. And then we look at the difference between these groups to see if there is a substantial disparity gap. So in 2019, when the first report was published, we were looking at race, ethnicity, payers, and geography. And with respect to race ethnicity, there was a substantial difference between the top performing group, which is the whites that had a screening rate of 79%, and the bottom performing group, which were the Asian and Pacific Islanders with a colon cancer screening rate of 68%. But that was the only substantial disparity gap. The other ones were either less than 4% difference or less than the 10% difference. And we also looked at payer disparities, and with respect to commercial and Medicare, the screening rates were 80%, but there was a substantial disparity gap between these top performers and Medicaid and uninsured, which had uninsured had screening rates of 66%, and Medicaid had a screening rate of 63% for colorectal cancer. And then when we looked at the rural and urban disparities, again, just using this binary rural versus urban, we found that the urban colorectal cancer screening rates were at 79%, and the rural colorectal cancer screening rates were at 75%. So we did not find any substantial geographic disparities here. But we really felt that this was probably limited by the fact that we only had these two binary categorizations of rural versus urban. And I was convinced that this is just not the whole picture. And that was because I had already started looking at some of the data in a little more detail from WCHQ. And so the preliminary data that I'd been looking at showed that there was a wide variation in colorectal cancer screening among Wisconsin primary care clinics. So here we have a number of health systems. We have a number of clinics that are within each of these health systems, some that are rural, some that are urban. And you can see that there's a wide range. So amongst the urban clinics, there's a range of screening rates from 31% to 90%. Amongst the rural clinics, there's a range from 33% to 85%. But what I really wanted to highlight here is that the top rural clinics were lagging behind the top urban clinics, and the number of top clinics that had screening rates above 80% was significantly more amongst the urban clinics than amongst the rural clinics. So we know it's a more detailed story than just rural versus urban. So the next year in the 2020 Wisconsin Health Disparities Report, we wanted to focus on just rural and urban populations. And again, this was a partnership between the WCHQ, the Health Innovation Program, where I do my research, and funded by the Wisconsin Partnership Program. So the first thing we did was work to create a novel rural-urban geodisparity model. And we based this on AHEC's Wisconsin urban-rural classification system for zip codes, with a slight change in one of the areas that they characterized as more rural, we characterized as more urban. And we used a conceptual model based on the adapted version of the Anderson Behavioral Model of Health, and did a cluster analysis looking at 11 different variables in 3 main domains related to healthcare capacity and healthcare resources. So we used that area health resources files to look at the ratio of primary care physicians per count to the county population. Same with mental health providers. For economic status, we looked at poverty. We looked at Medicaid, percent population without health insurance, education levels. And for health status, we looked at physical unhealthy days and mentally unhealthy days that were reported using the Wisconsin BRFIS data. And based on a cluster analysis, we were able to identify 6 distinct categories. So 3 rural and 3 urban. And we named these rural underserved, rural advantaged, and rural, which is the rural is a group that's neither underserved nor advantaged, and then the same kind of mirrored combination for urban. These were based on the zip code tabulation areas, and you can find the corresponding categories at hipexchange.org. This is a spreadsheet that you can download to include in your research as well. We know there are limitations to this categorization, this model that was created. We know some characteristics are at the county level, not the zip code level, based on the data that we used. And we do recognize that many characteristics that are related to access to healthcare and healthcare resources are not included. So, for example, we did not include data on access to healthy foods, incarceration rates, access to broadband. We also we excluded zip codes with less than 500 people, zip codes that were just assigned to PO boxes or organizations. And we did exclude zip codes that had missing values for any of the variables. But while doing this, we were able to show that things really kind of passed the sniff test. So if you look at the green dots are better than the state average for that measure. Yellow is at or near the state average, and red is worse than the state average. You can see that the rural underserved zip codes showed that their access to healthcare providers, poverty, uninsured, and Medicaid levels, educational attainment, and health status performed worse than the state average for all of those zip codes, while on the other side of the spectrum, the urban advantaged group performed better than the state average for all of those. And then the ones in between fell in a pattern that made sense. We also then mapped the zip codes across Wisconsin. And as we know, Wisconsin is a mostly rural state. So the left side of the screen, you see the Wisconsin, the rural, underserved, and rural advantaged zip codes, which take up most of the state. But we also know from living here that not every rural area is the same. And so that's, again, what this geo-disparity model is showing. We showed these mappings to a number of stakeholders across Wisconsin and they all agreed that this made sense, that the categorizations that we were able to come up with and how we were labeling different zip codes across Wisconsin made sense. So when we used this new 6-category system to look at disparities in multiple metrics in the 2020 Wisconsin Health Disparities Report, we are now able to see a more nuanced picture. And this is just the data from colorectal cancer screening. But this data shows that the highest performing group were the urban advantaged individuals, and the lowest performing group was the rural underserved. But you can also see the darker orange dot are the urban underserved, and their rates of screening were much closer to the rural underserved. But there were also some areas, the rural advantaged and rural, that were doing significantly better and closer to the screening rates of the urban advantaged groups. Again, with respect to the urban underserved, I want to point out that this does not include data from the federally qualified health centers, and that it is a small sample size. So what this showed us is that almost 4,000 more rural underserved adults in Wisconsin need to be screened for colorectal cancer to close this disparity gap compared to urban advantaged adults. And this was a substantial gap because there was a 10% difference. So this led me to my current research. And I just want to talk a little bit about what we've done so far with this grant from the Wisconsin Partnership Program that I am working with Marshfield Clinic Research Institute, the Health Innovation Program, and the Wisconsin Collaborative for Healthcare Quality. And what we're trying to do is identify successful colorectal cancer screening strategies across rural and urban settings in Wisconsin to meet that National Colorectal Cancer Roundtable goal of 80% screened in every community. We know that rural communities face different colorectal cancer screening obstacles compared to urban healthcare settings. And we also know that these distinctive barriers are often unaccounted for when interventions are being translated from urban areas to rural areas. And again, we want to achieve this national colorectal cancer roundtable goal of 80% in every community. And in order to do that, based on what we've learned from national trends and from trends across the US Midwest and our data on Wisconsin, we need to address gaps in rural, low income, and racial minority communities. And we also believe that we need to learn from the high performing clinics that are in each of these communities and learn from the individuals who are doing the best and are able to overcome the distinct barriers within those specific communities. So this is a data from an abstract that one of our current GI fellows, Dr. Václavic, who was also a chief resident here, helped me write and present. And so we were able to identify over 460,000 patients in Wisconsin who are eligible for colorectal cancer screening that are cared for by over 2,300 primary care providers in close to 300 primary care clinics across 14 different health systems that were member organizations of WCHQ. And in this map, you can see the classification of the zip codes based on the rural-urban categorization, and the black dots are the 271 primary care clinics that were included in this study. So we had good representation kind of across the state. And the overall screening rate for the sample was 79.2%. So that's great. Also, again, keeping in mind that this is data from health systems that voluntarily participate in WCHQ. So it's very possible that these are healthcare systems that are already very QI minded and thinking about quality improvement and healthcare metrics. We took the patient level electronic health record data from all of these patients and created multivariate logistic regression models to predict completion of colorectal cancer screening at the primary care clinic level. So each patient was assigned to a primary care clinic where they received most of their care. All of our models have adjusted for multi-level variables at the patient level, provider level, and clinic level, and then the healthcare system level. So specifically, we're controlling for patient age, sex, race, insurance, comorbidities, healthcare utilization. Providers, we're controlling for specialty, sex, number of patients that are eligible for colon cancer screening in that provider's panel. And at the clinic level, we're controlling for the number of providers in that clinic, the distance of that clinic to the nearest colonoscopy facility, demographics of the population in the surrounding community that clinic serves, and then whether or not the healthcare system that clinic belongs to is part of an academic or a community-based system. And the first thing we did was going back to that binary rural-urban categorization. And so now in this model, so the Wisconsin Health Disparities reports, we're just looking at the absolute screening rates. This model is now adding in and controlling for all of those different multi-level variables. And we again showed, yes, there is a difference between rural and urban completion of colorectal cancer screening. The difference after controlling for all of these variables is a little bit bigger of a difference than we saw previously, but still not as significant as I was expecting. So when we then add in our new geodisparity model, now we see, again, a more nuanced picture. We see that there is a much bigger difference between rural underserved and urban advantaged, as well as urban underserved and urban advantaged. And again, I want to point out that the urban underserved group is the smallest sample size that we have. But the rural advantaged areas and the rural areas were doing pretty close to the same screening rates as the urban advantaged and urban areas. So we concluded that utilization of a binary rural-urban classification shows significantly lower likelihood of colon cancer screening completion at rural compared to urban clinics. But a more detailed picture emerges when we use this novel geodisparity model. And so using this model showed us that compared to urban advantage clinics, there were significant disparities in both rural underserved and urban underserved clinics. And we're hoping that this novel 6-category system will help to better target interventions to achieve 80% screening in every community. In order to assess potential modifiers of this geographic variation across these 6 categories, we then performed an analysis using multiple interaction terms. And the only significant interaction term with clinic geolocation was the percent of patients in a provider's panel that self-identify as non-white. And so this really highlighted this intersectionality of rurality and race ethnicity. So as you can see across all of the settings, non-white individuals are less likely to complete colorectal cancer screening compared to white individuals. But even if you look at just the rural versus the urban, non-white individuals in the rural areas are even less likely than their non-white counterparts in most of the urban areas to complete colorectal cancer screening. So just again to highlight this, and this was another abstract that was presented by Dr. Václavic at Digestive Disease Week, our big GI conference. So she showed that non-white patients in underserved areas, both rural and urban, are less likely to complete screening. Non-white patients living in a rural area are even less likely to complete screening than their white counterparts, as well as compared to their non-white counterparts in urban, advantaged and urban areas. And this leads us to one of our kind of bigger conclusions, which is that interventions to increase colon cancer screening in racial and ethnic minorities now also really need to address the barriers that are specific to their geolocations as well. So trying to delve even a little bit deeper, one of the questions that we get asked at a lot of our presentations is, well, what about the type of screening test that is being used? Is there differences in that? And so this was an abstract that Dr. Václavic presented at the next year's Digestive Disease Week, where we looked at the utilization of test types, so categorized as stool-based screening versus structural exams. So we were looking at amongst the people who completed colorectal cancer screening in each of these areas, was there a difference in whether or not they used FIT testing or multi-target stool DNA versus colonoscopy, sigmoidoscopy, or CT colonography? And we found that patients living in rural areas are utilizing more stool-based screening over structural exams compared to urban areas. Not earth-shattering, but we're just presenting the data and proving that, yes, we know more stool-based tests are being used in rural areas. We also looked at just based on race, ethnicity, so categorizing white versus non-white. We know that non-white individuals are more likely to use stool-based tests than white individuals. And then if you look only within rural versus urban, rural non-white individuals are even more likely to use stool-based tests than rural white individuals. We also thought, well, maybe there's a difference between whether the clinic that the patients receive care at is a high-performing clinic or a low-performing clinic. And so we looked at clinic performance and defined high-performing clinics as clinics with greater than 80% screening rates, and saw that, interestingly, low and medium performing clinics were more likely to use stool-based tests than high-performing clinics. And that was actually counter to our initial hypothesis. We initially thought that higher performing clinics would be utilizing all sorts of screening tests and offering multiple options. And it seems like the higher performing clinics are actually utilizing more structural exams for colorectal cancer screening. And so that is contributing to our thoughts that there's probably significant infrastructure differences across high performing, medium and low performing clinics. And it's possibly has to do with access to colonoscopies and easy access to structural exams. And so our next step with our current grants are to further explore differences between these high-performing rural and urban primary care clinics utilizing qualitative interviews, which we've already started conducting and started doing a preliminary analysis from that data. We also have an American Cancer Society grant to delve deeper into the rural clinics, to expand the sample across the rural clinics across the upper Midwest, as well as including clinics that are in rural areas that are part of healthcare systems that do not participate in WCHQ. So we want to get a broader look at what's happening with respect to rural colorectal cancer screening. And then the goal is to develop a compendium of successful colon cancer screening strategies that are utilized in high-performing rural and high-performing urban clinics, and learn from the best, learn from the people who have been able to overcome the barriers that are specific to their geolocations. So if we can achieve 80% colorectal cancer screening in every community across Wisconsin in the next 5 years, we will screen approximately 125,000 more individuals and prevent 12,000 new cases of colon cancer and 4,500 deaths. So that is my overall long-term goal. So I would like to just take a moment to thank all these individuals on this slide who have contributed significantly to this research and to my career, my research career. So locally here at UW, Jay Ford in the School of Pharmacy is fantastic to collaborate with respect to qualitative research. Dandy Chen, Jessica Gao, and Guanhua Chen are great to work with in the biostats department. Jamie Lamantia is my research specialist. And then I wanted to give a shout out to Dr. Václavic, who is one of our GI fellows, former resident here, and Dr. Magalapalli, who is one of our current residents, both of whom have worked really closely with me to get our research presented at national meetings. And of course, we have amazing collaborators at the Wisconsin Healthcare Collaborative for Healthcare Quality, Brian Slattery, Renee Sutke, Matt Chagot, and I would not be where I am today without the support and collaboration of the Health Innovation Program with Maureen Smith and Katie Ronk. And the Marshfield Clinic is an amazing resource and community partner to collaborate with, especially if you are interested in doing research on rural and urban disparities. They support care and provide care to a large section of the rural patients in our state. Bob Greenlee is our collaborator from there. And again, the funding support that really has been supporting all this work is from the Wisconsin Partnership Program and the American Cancer Society. So with that, I am going to put my last slide up here so you can get your QR code to fill out the evaluation and prove that you attended. Thank you very much.
All right, well, thanks, Jen. First, a couple people already put in questions, but please, if you have questions, type it into the Q&A section on your computer. And thanks, Jen. That was actually a great talk. Actually, I really appreciate the Wisconsin-centric focus that talk, and really your research really does expand the Wisconsin idea that actually we at UW Health, our goal is to screen the entire state of Wisconsin. So I'm just going to start reading off some of the questions that come in. One from Dr. Patel's, which she is thinking big by asking, is there any way other states, or you said that Wisconsin's like a top 5 screen, could something like the WCHQ be joined by other states, or could we have national programs that fit your type of research, or is that happening?
Yeah, so I think that's an excellent question. So I don't know of any multi-state coalitions, but within multiple states, there are similar initiatives to the WCHQ. So Minnesota has an excellent group that's very similar to WCHQ. Iowa has the Iowa Cancer Consortium. Nebraska also has a similar cancer consortium. And so it would be fantastic if we could have these these state level organizations join a multi-state consortium, that would be great. As far as what we do right now, I've given talks at some of the Minnesota, the Iowa groups. So we are spreading our and sharing our best practices and what we're doing. But yeah, I think having these nodes in different states and then building out across the country would be fantastic.
All right, the questions are flying in. So Dr. Bartsley actually wondered, you mentioned this a couple times, is there any way your work can work with the Wisconsin tribal nations and tribal health clinics as far as their screening rates?
Yeah, and so that is my kind of next step of what I'd really like to do. Right now, the data I have is from the Wisconsin Collaborative for Healthcare Quality, and they are not part of that. So I would like to start to make relationships and inroads with individuals in those areas to be able to join our data. I do have some contacts in Wisconsin and also some in Minnesota with the tribal health services. And that's my next area of interest.
All right. Dr. Cohen, actually, a very interesting question, actually, is sort of, and this is the next step, what can the individual physician or clinical provider do to help out with this problem in their own clinic?
Yeah, so participate in our qualitative interviews if we ask for recruitment. That's helpful. But also, I think just being cognizant of what is happening in your clinic with respect to colon cancer screening, and what is happening with respect to different groups of patients that you serve. So what we've kind of learned with some of these qualitative interviews is that a lot of providers would be very interested in knowing a better breakdown of their screening rates within their panels with respect to racial and ethnic groups. So they might know overall what their screening rate is, but they don't have an idea of how they're doing with respect to patients who have Medicaid, or how they're doing with respect to Hispanic patients or non-Hispanic Black patients. And I think that having that information would be very helpful on an individual level. And you might then be able to identify certain innovative strategies you're using with particular groups that you can then share with other people.
There's a couple of questions coming in about screening particular groups. Any need to screen certain ethnic groups earlier, like African Americans or Hispanic patients that have higher rates?
As of right now, no. Although, interestingly, a while ago, and Pat, this, the American College of Gastroenterology had recommended starting screening rates for African Americans at age 45. That was a long time ago. Now, we've changed to decrease the screening rates for everybody to 45, and there has been no move to decrease the rate, the age to start screening in any racial and ethnic group lower than that.
And here's a very pertinent question right now is, how are we doing better as far as the younger individuals? We hear that's in the popular press all the time of the increased colon cancer incidence. And how can we address this at UW and statewide and nationally?
Yeah, so the data in my study did not look at age 45 to 49 because it was utilizing retrospective longitudinal data. And so we did only include people who were age 50 to 75 because that was the screening rate recommendations at that time. So WCHQ now, I believe, is publicly reporting screening rates lowering the age to 45. And if you look, across the state of Wisconsin, every healthcare system, their screening rates are going to go down right away because we're just adding so many more people to our screening queue. And so I think that's really the biggest issue is we are reaching them, but the resources that we all have across the state, across the country to be able to screen individuals in this 45 to 49-year-old age group, it's just not adequate.
Yeah, and we know that at UW, that happened all at once. The 45 to 49-year-olds were recommended to get screening, and all of a sudden, almost 40,000 new shared lives had to be screened instantaneously, which was, there isn't the person power. That's quite a challenge to screen all these younger people, actually, and we're dealing with that even at UW and Madison, which is probably a high screening area. That Castillo asked a question too, is sort of like, there seems to be in your presentation that there are sort of, we hear of food deserts, there are colorectal cancer screening deserts. And he asked, is there any direct to the customer or the consumer, or how do you get this information to the people who aren't being screened?
Yeah, so I agree. I think that's one of the biggest issues is to get screened, you essentially have to receive care from a primary care provider. You have to have some access to a healthcare system. And so there's actually some novel studies looking at utilizing the emergency department with respect to cervical cancer screening. And I wonder if we can do something similar to that. So that would be potentially reaching individuals who are maybe not having regular primary healthcare providers, but utilizing the emergency department on a more regular basis. So maybe having fit tests available and saying, hey, here, while you're here, we noticed you weren't up to date with screening. You should take this home. Obviously not doing it during that emergency room visit, but I think there are definite ways for us to increase and reach the people that are not regularly being seen by their healthcare providers. And that's what we need. We need those innovative strategies. And Cologuard or Exact Sciences is working to be able to try to partner with some of these more rural healthcare systems to help them mail kits directly to patients' homes. So we do need to meet people where they're at.
Yeah, this is not meant to be a political question, but do you think we have the funding and the person power to address these disparities at UW and in the state and even nationally? I mean, you have the ideas, you know how to do it, but can we do it? But do we have the funding and resources to do that?
I think that in order to have the funding and resources, and because resources are finite at this point, it would be a huge culture shift where we really would have to do more of like a hybrid of what they do in Europe, where maybe everybody who is average risk, not just 45 to 49, but all ages, you go to stool-based tests first, and then we save the colonoscopy resources for individuals who have those positive stool-based tests or are considered high risk based on family history or personal history. I mean, we already do different screening tests for individuals with breast cancer risk based on whether you're high risk or average risk. So I know this is controversial coming from a gastroenterologist, but not every person needs a colonoscopy. I'm going to say that, and I'm like gritting my teeth as I'm saying it, but it's true. There is no way that we are going to be able to screen everyone without utilizing all of the resources that we have on hand and using them in a smarter way.
And this is sort of goes maybe to some of your older research, Jen. This question here is, why do some patients never engage in screening? I mean, why do we shoot for 80% screening rate instead of 100%?
Right. So I think we do definitely see a plateau, a ceiling effect in essentially all metrics. I don't know if we'll ever be able to reach 100%. If we look at data where people have done qualitative research interviewing individuals who are not up to date with colorectal cancer screening, it's interesting because still the vast majority of them say that it's because it was never recommended to them by their primary care provider. Now, whether it was never recommended or it was something that was just not important for them to hear at that time, that's another story. But their perception is that it wasn't recommended by their primary care provider. So I mean, I still think there are a number of people that we can reach out there, but we need to find a different way to get the message to them.
No, I think the focus is at primary care and that original contacts. I think we have some of your research before has shown that our different clinics perform much better than other clinics, and not that they all did well, but I think like Weiss Clinic for a while, it may still be, had screen rates over 90%, which is unheard of nationally. And so whoever works in primary care at Weiss Clinic, and whatever you're doing is the correct thing to do. It's really, I think, contact the patient, and 90% screen is huge. So again, it really goes back to primary care and first contact. Let me show you. I have a couple more questions for you here. Here's a simple question. What do you think the difference is for why the Asian population has gone up in screening and really the Black population has plateaued?
So my hypothesis, and I have not looked into this in our own data or in the literature in depth, but I think this is where we're starting to hit the inequalities with access to care, being able to access regular healthcare, being able to access high quality healthcare, and being able to access high quality early detection and treatment.
I think we have 2 minutes left, and Dr. Castillo's another question actually, which is I sort of goes to a broader question: is yes, is there similar to the bookmobiles that went out? Could we have colorectal cancer screening units that go to the underserved areas? It's probably the big question. We identify the disparities. What actually can be done now? If you in 1 minute, can you say what's the next steps? How can we get these disparities to go away or make them closer at least?
So if I had to summarize it, my big idea would be, as I said before, not everyone needs a colonoscopy. We need to do a better job figuring out who can get the stool-based tests and who we should save the colonoscopies for. And with respect to Rodrigo's question, so the mobile colon cancer screening unit, so that's an idea that honestly, there are mobile mammography units that some of the rural clinics are using. And so what if we also hand out FIT tests at those mobile mammogram visits? What about pairing multiple screening tests together, lung cancer screening, mammograms, and FIT testing? I mean, we need to get to people and give them access to preventive health screenings at the same time, and with respect to multiple diseases. We can't expect people to come in for a separate appointment for their breast cancer screening, a separate appointment for their colon cancer screening, a separate appointment for prostate cancer screening, or what have you. I mean, time is precious, resources are precious.
All right. Well, thanks, Jen. That really, I think the topic of your talk really shows how much it hits everybody, how many questions you had. I mean, it affects everybody over 45, all of us. It affects all of us as physicians. And I think it really affects talks to our responsibility as doctors to close these gaps and disparities. So thank you very much. A fantastic talk. And I think I got to almost everybody's questions. I feel bad. I apologize if I didn't get to everyone's, but that's because of the number of questions that Jen got. All right. Thank you.
Thank you, everybody.